Hypotony is the most common complication of all valve surgeries. It is more common in the non-valve glaucoma drainage devices. It results from the wound leakage, inflammation, or incomplete occlusion of the tube, or the large venting slit with the non-valve implants. Management: if the chamber is formed, then it is a conservative management, and if there is the tube touching the cornea or the lens, then the viscoelastic substance has to be injected. If choroidal effusion is associated, that can be treated with the corticosteroids and cycloplegic agents. If all the measures fail, then the surgical revision may be required. Valve malfunction is very rare complication. That's why we need to prime the valve at the time of surgery, and the careful handling is very essential at the time of insertion of the valve. Hyphema is common with the neovascular glaucoma, and nowadays it is coming down due to the preoperative previous use of anti-VEGF agents. Scleral perforation is also a rare, but it is seen in the ophthalmic eyes and the eyes with the collagen vascular diseases. Tube related complication: first of all, the tube positioning. If it is positioned very anterior, then it may touch the corneal endothelium and leads to the corneal decompensation. If it is posteriorly placed, it may rub the iris and causes the inflammation, and it can also touch the anterior capsule to lead to the cataract formation. Tube blockage can occur by the blood, vitreous, fibrin, or the iris incarceration. Sometimes ND-YAG laser and vitrectomy may be useful. If it is a clotted blood, tissue plasminogen activator may be beneficial. It is also noticed that if the AGV is inserted through the pars plana route, kinking can be occur. That can be overcome by using the newer design with a pars plana clip. Tube retraction is more common in the children's eye. As the eyes grows up, the tube retraction occurs, and it can be lengthened by the tube extender, or alternatively it can be placed by the pars plana route. Tube erosion are due to the conjunctiva melting at the limbal site or the poor patch graft placement. It can be repaired or mobilizing the conjunctival graft. Endophthalmitis, it is more common in the exposed tubes and the plates, and it should be dealt as a surgical emergency, and it is more common in the children. Plate migration and expulsion are very less common and can be result from the anterior placement of the plates. Corneal decompensation is due to the poor placement of the anterior tubes or the flatness of the anterior chamber. Valvular devices leads to the better maintenance of the anterior chamber, or we can place the tubes in the pars plana route to overcome the corneal decompensation. Overhanging blebs are due to the patch graft is too thick or the plate is too anteriorly placed. It can result in the chronic Dallen formation or the ocular irritation. It can be prevented by the appropriate size of the patch graft and the appropriate placement of the valve. Squints are common in the inferior placement of the plates, and that can be result due to the scarring or the entrapment of the muscles. This kind of secondary diplopia is difficult to treat. The options we have the prism or the muscle surgery correction, and if all the fails, then the removal of the drainage devices can. Hypertensive phase occurs usually after 1 to 6 weeks post-operatively, and it is more common with the valve implants, and it leads to the rise in the pressure from 30 to 50 mm of mercury. Thank you.